are in Revew, and for those who just joined us, we are on the 7th day of the 90-day free NCLEX review classes, which we schedule daily at 12 p.m. Eastern Standard Time. And so we're still covering all the nursing subjects and rationalization of 2000 NCLEX style questions. But today I'll talk about the nursing care and the management for an adult patient with pyelonephritis, and we'll have some Q&A right after. Now, talking about the pyelonephritis, this is a sudden onset infection and also the inflammation of the kidney and upper urinary tract, which can affect either one or both kidneys. So let's talk about the etiology and the disease process of the pyelonephritis, and we will be focusing on the causes and the mechanism. Now, first up here is the presence of the E. coli. This is a very common microorganism in the gastrointestinal tract, and this is the primary culprit for many urinary tract infections, including the pyelonephritis. So the journey of the E. coli from in the urinary tract, the E. coli can now adhere to the bladder wall, or it can enter the urethra and eventually ascending to the kidneys and also causing the infection. Now, while the E. coli is the most prevalent, there are also other bacteria that can also cause pyelonephritis. So we also have the Proteus, Klebsiella, Pseudomonas, and these are examples of the gram-negative bacteria that can also cause kidney infections, especially in the healthcare settings or for those individuals with compromised immune systems. Now, for the gram-positive bacteria like Enterococcus, or it could be the Staphylococcus aureus, although these are less common, they can also contribute to the development of the pyelonephritis. Now, namely, we have the Staphylococcus aureus, which is basically something that can enter via the bloodstream from a very distant infection site. And this can also travel into the kidneys. Imagine that, Staphylococcus aureus. And this can also lead to acute pyelonephritis from the bloodstream, and it can also ascend from the lower urinary tract. Now, let's talk about the mechanisms here between the acute and also the chronic pyelonephritis. And with the acute pyelonephritis, we're going to start with talking about the travel of the bacteria coming from the lower urinary tract through the urethra, and it will ascend to the kidneys. Now, again, don't forget, guys, that we are talking about the kidneys. This is the site of the attack. It's not the urethra, it's not the ureter. We're talking about the kidney itself. Now, the ascending route is actually facilitated by so many factors. Again, sexual activity, or it could be an introduction of a catheter. Maybe the practice of catheterization is not very sterile, or it could be some anatomical abnormalities that can also impair the flow of the urine. Upon reaching through the kidneys, though, the bacteria can now adhere and it will invade the renal parenchyma. And so at this point, this will now trigger an immune response. Now, at this point, the immune system will also release those chemical mediators, and this will potentiate the symptoms of pyelonephritis. And we will know that the person now will suffer some fever, could be chills, and there could be some flank pain, or it could be difficulty urination, or maybe some pain during urination. And so if this is left untreated, the acute pyelonephritis can also progress to a much more severe complication, such as the renal abscess formation, or it could even cause septic shock. Now, this is the big deal right here. Septic shock can happen anytime, whenever there is going to be cross-contamination or crossover of that microorganism into the bloodstream. Now, as we know that one of those microorganisms is the Staphylococcus aureus, and this is potentially going to be one of those microorganisms that will lead to septic shock. Now, talking about the chronic pyelonephritis, This is something that will typically develop over a much more prolonged period. And this is described as being recurrent, or it could be persistent renal infection. So, supposing the person might have some kind of like treatment, and they probably did not complete the antibiotic therapy. And so, this patient will now probably have some recurrence of the pyelonephritis, and this can happen anytime as well. And with this type of pyelonephritis, this is going to be caused by so many forms of blockages, and part of that is the VUR, or we call as the vesicoureteral reflux. And this is that section near the end point of the ureter and to the bladder. And so this is the area that can cause the urine to flow backward. And so from the bladder, the urine will actually kind of get sucked in. It will go up into the ureter and eventually will reach into the kidneys. And of course, the microorganism being transported there. And so this is going to increase the risk of the bacterial colonization and the recurrence of the infection. And so the VUR, again, this is the vesicoureteral reflux. This is associated with congenital anomalies of the urinary tract, and this can also lead to scarring. And I'm talking about the scarring of the ureter. So if this is going to cause some scarring to the ureter and also part of the parenchyma, this can also lead to dysfunction of the kidney over time. Now, another cause here is the struvite calculi. We discussed this yesterday, that the struvite stones are composed mostly of the magnesium, the ammonium phosphate, and they can form in the urinary tract, and they're actually going to cause this, or they will provide as a nidus for bacterial growth. And this will really cause the recurrence of the pyelonephritis. So think about the struvite calculi. This is going to be one of those predisposing factors here. Now, lastly, we're going to talk about the obstructive uropathy. So this is pertaining to any condition that can cause obstruction, the flow of urine from the kidneys to the bladder, and can also predispose the individuals to the chronic pyelonephritis. So again, if we were talking about the obstructive uropathy, we are talking about urinary tract strictures, or it could be the benign prostatic hyperplasia, or the BPH, or the presence of the ureteral stones. So get reminded for those different possible causes here. Again, strictures, we have the BPH and the presence of the stones. Now, as we know that these causes of obstruction can, again, will lead to the stasis of the urine, meaning there is stagnation of the urine in the upper section of the urinary tract. And this will cause the bacteria to grow, and it will cause the inflammation directly into the surrounding tissue. And again, over time, when there is the reflux because of the obstruction, this can cause the scarring of the kidney itself, and again, can impair the kidney function, and it will become irreversible. Now, we're going to talk about the differences here between the acute pyelonephritis and the chronic pyelonephritis. So you got to pay attention into the different key differences here. Now, with the acute pyelonephritis, this is going to occur as probably a new infection, or it could be a recurrent infection, meaning it will typically hit you out of the blue, and it can be either a brand new infection or a comeback from a previous bout that probably there was no non-compliance of the antibiotic therapy. So imagine just waking up feeling fine one morning, and by afternoon you're already down with a fever and chills. And so this is classic about the acute pyelonephritis. Now, another thing that you're going to take note of the acute pyelonephritis is the bacteremia. So this is really going to hit you out of the blue, and it is, again, either a brand new infection or it could be a comeback from a previous bout. And so again, this will actually cause some sepsis as well into that person if this is undetected. Now, we're going to have to talk about the possibility that this acute pyelonephritis can lead into a chronic form, and eventually, if this is not treated, over time, this will cause impairment of the kidney function. So the person might go into acute renal failure or CKD. All right. Now, for the assessment findings here, you got to pay attention here because there are some similarities. However, there are so many variations here. But for the acute pyelonephritis, the person will experience the high fever. Of course, this is the normal body response to fight off the invading microorganism. And there will be some chills. So it's just like having an internal cold snap that even though your body's on fire with fever, you just can't stop shivering. And one of the responses here will be a rapid respiratory rate, or it could be a rapid heart rate. And so your heart rate will be racing, just like doing a marathon, and your breaths are coming in short. They're going to be a little bit of like burst of rapid pattern. And this is really one way that your body is trying to cope with the infection. Now, the nausea is something that you would feel like you're getting queasy, and it's like a roller coaster. It just comes on and it will go away, but just for a few periods of time, and it will come back. Now, for the pain, this is a common manifestation that is going to occur on the affected side. And we are talking about the kidney that is infected, because this is not going to be bilateral, okay? So it's going to be either, or could be really two kidneys, but it's not like if the infected kidney is only on the right side that it will cause pain. No, it will be localized. And you have to imagine like the kind of pain that the patient will experience here will be somewhat dull, it will be throbbing ache, and this will be unilateral on the backside. And this is not going to be a sharp kind of pain sensation. It's just uncomfortable, like throbbing, dull pain. Now, for the tenderness in the costovertebral angle, take note of this. This is one bit more specific at this point. So it's like having a sore spot when someone pokes you on the back just below your ribs. So this is something that would be classic to the acute pyelonephritis. Now the patient here will also experience some headache, and the characteristic headache here, it's just like a drum pounding inside your skull, making it every noise, and also the movement will feel like an assault on your senses. And then the patient will also have some painful urination. So they will have that stinging sensation they get when they accidentally touch a hot stove, just like that. And the frequency, and there's also urgency to urinate. So they have that feeling to go to use the bathroom every 5 minutes. And this is really going to be bothering, especially for those older population. Now, the patient will also manifest some bloody and cloudy urine. So please take note of this. This is something that can come back in any NCLEX test question, because this is usually the description about the pyelonephritis, especially the acute type. So this is because of the mixture or the presence of the hematuria. And together with the infection, it will cause that cloudiness. So it just kind of looks like a tomato juice, or like a mixture of like a yellowish color with a tomato juice. And it's very cloudy that you cannot see through it. All right. Now it can be foul smelling. So you know that funky odor that hits you when you open a garbage that been sitting there for like a while? That is the kind of smell that you will be smelling from this kind of urine. Now, along with that, there will be increase in the white blood cell count in the urine. All right. So this is going to be greater than 5 WBCs per HPF. So the white blood cells are actually camping out in your urine, ready to fight off the invaders. That's why they are going to be abundant in the urine. So definitely this is one of those key features telling you that there is an active infection in the urinary tract. Now for the chronic pyelonephritis, the patient here is usually probably asymptomatic up until there is going to be an infection, or let's say there is an exacerbation. Because when they have the chronic pyelonephritis, there's also some damage that has been done into the parenchyma. But on top of that, if there is an incoming infection, then that will make them a little bit similar to the acute pyelonephritis. And talking about this type of pyelonephritis, this is going to happen much more kind of slow. It can be gradual, and it kind of creeps up on you over time. And this is going to be as a result to recurrence of the infections, and it's just like a nagging ache that never seems to go away. Now here, this is the type of the pyelonephritis wherein there is tissue scarring and also the formation of fibrosis in the ureter and also the formation of the strictures. It's no fun because if there is now narrowing of the passageway in the ureter, well, it will make the urination process much harder, especially or draining the urine from the calyces into the bladder where it's supposed to be collected. And so once there is now a decreased size in the lumen, there is a higher chance that those urinary or the urine that's supposed to go down into the bladder can go back up some more and can impair the kidney function. It's going to make things much worse. Now, with this chronic pyelonephritis, it will actually cause to develop acute kidney injury or chronic kidney disease. So this is something that we need to really control, make sure that we are treating our patient, make sure they are compliant with the antibiotic therapy, because this is really one of those modalities that we can prevent it from progressing. Now, for the assessment findings, please take note that the person here or the patient can also manifest the fever, especially if there is an accompanying infection. And so the body will respond through elevating its body temperature to fight off the infection. And there's also going to be flank or abdominal pain because the kidneys are located in the flank area, and also the inflammation or the infection of the renal tissue. This can also cause some discomfort, and it will radiate to the abdomen because of its proximity to the kidneys and also sharing the nerve pathways. So again, this is the radiation of pain from, or localization of the pain in the flank area and also the abdominal pain. So quite different though from the renal calculi that we talked about yesterday, because with the renal calculi, the pain is supposed to radiate starting with the flank area, and when the stone passes into the urinary tract, the pain will kind of go down somewhere into the groin area. But here, with the chronic pyelonephritis and acute pyelonephritis, the pain will be localized and somewhat kind of steady. Now, the patient will also have some malaise and also anorexia, feelings of just fatigued, no appetite at all. And this is part of the process wherein the body is trying to fight off the infection. Another thing is that there is failure to retain the sodium. And the reason for that, it's because there is now a huge damage in the kidneys wherein it is now losing its ability to properly filter and also reabsorb the sodium. And this is now going to lead to imbalances. So this is what's one of the differences here between the chronic pyelonephritis from the acute, because of the impairment of the kidney function here. So again, there will be failure to retain sodium. Now, there's also impairment of the urine concentration, because the pyelonephritis in this type, it's causing the damage into the renal tubules already, and this is impairing its ability to concentrate the urine. And that is why there will be some polyuria excessive production of the urine, and in some cases, it can also cause nocturia. So how bothering is that? Now, part of the assessment finding here is the presence of pus in the urine. So this is basically consisting of the white blood cells in the urine, basically telling you that there is an ongoing infection. Now, the pyuria is a common finding in chronic pyelonephritis, again, because of the persistent bacterial presence and also the immune response by the body. Now here, there is a significant elevation of both BUN and creatinine, and we don't have that in the acute pyelonephritis. And the reason for that is because of the damage that it has done to the renal parenchyma. So what you're going to expect here is the accumulation of the nitrogenous waste in the bloodstream. And of course, if not detected or if not treated, it can lead to AKI or ARF. Now, another key feature here is the proteinuria, wherein there is now excretion of those protein molecules into the urine because of the damaged glomeruli. The tubules of the kidneys can actually become so permeable that it will allow the urine to, or it will allow the protein rather, to leak into the urine. So that is why when you are testing the urine itself, then this is going to be abundant. And again, a sign of the kidney damage wherein there's already impairment in the filtration. Now, here in chronic pyelonephritis, this is going to be isolated here. The hypertension, okay, is going to be present in chronic pyelonephritis, and it is because to so many factors. It could be from the renal scarring, or could be, yeah, definitely that one. This is going to cause a reduction in the blood flow, and it will trigger the renin-angiotensin-aldosterone system. And once this is stimulated, this is going to cause dysfunction. And please take note, guys, that the nephron already has an issue, right? It's not able to retain the sodium. It's not able to really concentrate the urine. And so even though there is a release or activation of the RAS, what it can do only is to cause vasoconstriction of the blood vessels. That's why there is hypertension. However, there is no more additional fluid volume because it's losing its ability to reabsorb the sodium and also the water. And this is why the effect of the RAS is only isolated to, or it only is going to cause vasoconstriction, not really about retaining the salt in the water. Now, when the patient will try to urinate, they will have that burning sensation. And this is going to indicate that there is also lower urinary tract infection that may coexist with the pyelonephritis. And also, this is an infection, or the burning sensation is really associated with the inflammation in either the upper or the lower tract as well. Now, the edema. This is because of the impairment of the kidney function, again, inability to get rid of those toxic waste products. So it can lead to retention of those wastes and also portion of the fluid. And again, it cannot really excrete some portion of the sodium. And this will now cause accumulation of the fluid inside the tissues. It's not really congregating into the, what do you call this, the vascular compartment, but it is accumulating inside the interstitial spaces, especially the lower extremities, dependent type of edema. Now, itching is another feature here wherein the person will have pruritus. And the reason for that is because of the accumulated products such as the urea, which is going to be present in the patient's skin. And this is one way of the body to get rid of those salts. It will go to the it will try to escape through the skin because of its inability to filter out these toxins through the kidney. Now we're going to talk about there's also polyuria and polydipsia, and the reason for that it's because of and so the body is actually going to lose so much of the water, and along with that, the reason is because of the proteinuria. Again, remember the action of the protein as a sponge effect, which is no longer there. And so as a response, the body will be thirsty. The body will tell those cells to get some more water to at least stabilize the hydration. Now, this is going to be a vicious cycle as well because of the impairment in the kidney function. Now, we're going to talk about the complications here. And one of those complications is the sepsis. This is the main issue that we need to keep an eye out because, again, the bacteria has already spread into the bloodstream, and this will cause the systemic inflammatory response. Okay, so this is no joke. This is a time when the patient's vital signs will get a little bit wonky. There will be widespread dilation of the blood vessels because of the release of those chemical mediators. They're making the lining of the blood vessels more permeable. And so this vasodilation and leaking of these fluids into the interstitial spaces can actually cause the blood pressure to go down considerably and also affecting the blood supply to the major organs. And so your patient's blood supply to the brain will be affected. There will be some confusion, disorientation, and the same thing with the other major organs in the body, like the liver, the lungs, also the peripheral tissues. And so this is something that you need to keep an eye on. Now, as we know that the sepsis will also include fever. There's also tachycardia, tachypnea. The person will get confused. And again, we have to deal this kind of situation very fast, rapid. Usually we're going to call for the rapid response team when there is now evident changes in the hemodynamics. And so we want to make sure that we are dealing with this situation really fast. Now, there's also going to be tissue death in the kidney papillae, and this will lead to the renal failure. And again, this is attributed to the severe or recurrent pyelonephritis, which can cause the necrosis of the papillae. And this is also a condition that can impair the kidney function and can contribute to either ARF or the CKD. Now, what is the manifestation here when there is tissue death? Well, this is a time when the patient really will feel that costovertebral angle tenderness. There is that flank pain, and then they're also going to manifest some blood in the urine. It could be blood tinge, or in some cases, maybe it's not visible yet. Maybe there's presence of red blood cells in the microscopic study of the urine. And also it can impair the urinary function. Now, another complication is the kidney abscess. And this is going to require drainage and also a prolonged antibiotic treatment. Okay? Abscess in the kidney is no joke. And again, this is a collection of pus or a pocket of pus inside the kidney. And this can be very painful as well and hard to treat with just antibiotics. So there is a need to really do a drainage incision into the kidney in order to properly clear those pockets of pus. Now, also the infection can spread around the abscess and also the fatty tissue around the kidney. And similar to the kidney abscess that is actually located outside, and it will cause some pain, it will cause some fever, and definitely the person here will need prompt antibiotic therapy. Now, please take note, guys, that the complication will go on, and this is your intestinal paralysis, or known as the paralytic ileus. And so you gotta keep an eye on to the bowel sounds of your patient, because an infection in the kidney with the proximity of these organs, this can also cause the peristaltic movements of the intestine to stop. And this will cause some pain into the abdomen. The person will end up with bloating, constipation, and the danger here, when there is unresolved paralytic ileus, it can cause necrosis and also perforation of the bowel, which will also lead to sepsis. It's just really a vicious cycle here if untreated. Now, you'll see here already about the different diagnostic tests. We got the urinalysis, and partly with the use of the dipstick test, urine culture, complete blood count, abdominal CAT scan, intravenous pyelography, or the renal ultrasound, or the use of the blood culture. Now, with the urinalysis, this is going to again detect the white blood cells, also the red blood cells. It will detect the microorganism there, the type of bacteria, and the nitrites. Please take note of the nitrites. This is one of those components that would actually give you an idea that the patient really has an infection or a urinary tract infection. And there will be presence of the cell cast as well. All right. Now, this is the primary diagnostic test that would be ordered by the physician in order to assess for the infection. And usually the test will also involve the use of the dipstick or a microscope in order to examine those indicators of infection, with the involvement of the white blood cells, the bacteria, and also the urinalysis with a dipstick test. It can detect those cell casts as well. Now, talking about the urinary culture, this will really pinpoint the kind of microorganism that is infecting the kidney. And again, this will really help out in the treatment, because this will identify the kind of microorganism that is sensitive to this particular antibiotic therapy. So this will really allow the microbiologist to test for the susceptibility of the microorganism to different kind of antibiotics that will be used during the culturing process. Now, this will also differentiate the true infection and possible contamination of the sample during that collection. That is why urine culture is one of the mainstays in the diagnostic testing. Now, here we have the complete blood count, which will show the white blood cells with, of course, elevation of the neutrophils and the bands. And this is really going to be a common finding in pyelonephritis. And for the CT scan of the abdomen, this is going to be done with contrast media. And again, this is the preferred method of checking the pyelonephritis because of its high sensitivity and specificity in viewing the renal parenchyma. Now, part of that is to also get some much more detailed images of the kidneys and also the ureter to check if there's any strictures or if there's any fibrosis, and to check if there is any pockets of abscess or pus inside the kidney. Now, the contrast itself, the dye that will be used, will really enhance the visualization, because this is done in real time with the imaging process with the radiology. So once the dye is injected, it will readily allow the medical provider to view it real time to see those areas that actually show obstruction. And we also have the renal ultrasound, which is going to be a useful diagnostic test. This is going to be one of those tests that can be used for those pregnant women, especially in the first trimester, suffering from the pyelonephritis. Again, this is a non-invasive procedure, really going to be able to visualize the kidneys and the surrounding tissues or structures. Now, we also have the blood cultures. I've talked about that already, and the intravenous pyelography. So when the test is going to involve the injection of the contrast media, again, don't forget about your role in screening your patient for their history to an allergic reaction from any contrast media, because this is something that would be very important. They're not going to be able to tolerate the contrast media. They could probably end up with anaphylaxis. And also to check for their kidney function to see about their creatinine level, the GFR, and the creatinine clearance. In some cases, though, some doctors will allow the injection of the contrast media, but they usually will have to pre-medicate the patient to make sure that it will not cause more damage into the kidney parenchyma. And after that, there's a need for us to really hydrate the patient with IV fluids, or also allowing them to increase their intake of oral fluids. And because we want to flush the contrast media out of the body. And this should be done within the next 24 to 36 hours. Now we are going to proceed with the different medical management involved with the pyelonephritis. And so part of that is going to be the hospitalization. We're really in the severe case of pyelonephritis, possibly when the patient is in the sepsis already. This would really require them to be admitted to the critical care. Or let's say they have some form of dehydration that would really require infusion of IV fluids, something that the patient would not be able to do at home. They are not going to be able to tolerate ingestion of oral fluids because they're also nauseous. Or let's say, for example, there is an ongoing obstruction in the outflow of the urine. And again, this is something that could cause rapid impairment into the kidney parenchyma. Another thing is that with the hospitalization, really, it will allow us to closely monitor the patient. Also with the administration of the IV antibiotics, that would really require us to administer them in timely manner. Like the intervals of the administration should be strict in order for us to deliver the medication and to allow much more therapeutic levels of the medication in their bloodstream. Now, another is the initiation of the IV antibiotics as well, especially during the admission. So usually in the ED already, they're going to start the antibiotic, and we're going to have to follow through with the succeeding doses. And this is something that is done early on to combat the infection effectively. And so we know that those medications are the fluoroquinolones, like the Livaquin, or the ciprofloxacin, or the aminoglycosides, or the broad spectrum cephalosporin. So these are the different classifications of the antibiotics that will be used. And of course, this is going to be according to the type of organism that it is, that has been found in the urine culture or the blood culture. And this is something that can be adjusted as well based on the succeeding urine culture and also the sensitivity testing. Now, this is going to transition into the treatment will transition to the administration of the oral antibiotics once the patient will be much more stable. Let's say they're able now to ingest oral form of the antibiotic, or let's say there is now the fever has subsided already, or let's say the blood pressure has been much more stable. And so the oral antibiotics will be much more suitable at this time. Now, this is something that can occur about 24 hours usually. I mean, the transition time itself. And again, when there is, let's say, in a case of a person or a patient that has the pyelonephritis, and this is probably something that is manageable at home, and so this is going to be treated as an outpatient basis as well. And this is something that we can, if you are going to be the urgent nurse or urgent care nurse, or maybe you're in the outpatient clinic, you can also provide the teaching to this patient of what kind of antibiotics that they're going to be taking for the duration. And usually it will take about 10 to 14 days to finish the entire regimen. Okay. And these are your fluoroquinolones or the cotrimoxazole, and it has to be completed within that time frame. Now, after that, they're going to need to show up for the follow-up appointment in order to monitor the progress and to see if their urine will also show the same bacteria. Because if it's not gone, if it's not eradicated, then the antibiotic therapy will probably be prolonged at this point. Now, this time there is really a need to follow up on the blood cultures after the visit, and this is again going to detect any kind of antibiotic resistance that may have developed, because again, this is going to be a recurrent type of urinary tract infection. So it's time probably to switch into a different kind of antibiotic. And so again, it's dependent on the blood culture. We're going to move on to the nursing care management here. And so this is going to involve a much more comprehensive approach in monitoring the manifestations and also the complications, and definitely will require us to educate the patient for long-term health maintenance. And so part of the care here is to monitor the patient's symptoms and also to evaluate the patient's ability to eat or drink, also their vital signs, and also we're going to have to check on their urologic history. How long probably they have been experiencing this problem. Do they have this for several years already? Maybe a vesico-ureteral congenital anomaly has been going on for several years. And definitely we are going to prioritize if there are any signs of sepsis. Again, this can really happen very fast. Within just a matter of few hours, the patient can go downhill. Our role here is to also check the patient's bowel sounds for a possible intestinal paralysis. We call the paralytic ileus because of the proximity of the bowels to the infected kidney. We have to monitor it at least once a shift. All right. So if the patient probably would be saying that they haven't really passed anaphylactus, or when you are auscultating the bowels, you're only hearing some tinkling here and there, even though they have been eating the regular food or meals, that is very concerning. If you're only hearing few of the bowel sounds, it can possibly lead to a much more worse form. Now, we have to also obtain the patient's history of any recurring infections or the recurrence of the urinary tract infections, because again, let's say, for example, the Proteus type of stone that can lead into the urinary tract infection. Now, we are going to administer the medications as prescribed, starting with the antibiotics, of course, and this is going to be based on the culture, and the antipyretics to treat the high temperature. And in order for us to manage the high fever, especially for those patients that are probably at 41 degrees Celsius, that's very high. So what we can do here is to use the cooling blankets or ice packs. And please take note, guys, that the administration of the cooling blankets can require the prescription from the medical provider. So anything that would require these devices to cool down the temperature, or let's say to warm the body temperature, that would involve the use of machinery, then definitely it has to be ordered. And this is something that you need to apply on this person with a high fever in order to prevent the complications. Now, we're going to have to treat the dehydration, especially with the oral IV fluids maybe, in order to combat the hypotension, in order also to allow much more stable hemodynamics into the patient. Like I've said, in one of the experiences I had with that one elderly patient, again, that low blood pressure can considerably affect the other systems in the body if I had let that happen to just keep going downhill without treating, without administering any bolus or antibiotics. Now, we're also going to monitor the patient's blood tests, including the blood cultures, so we can get updated with the different results in the white blood cell count or the CBC, the electrolytes as well. We're going to be able to report those in a much more real time if we are monitoring them strictly. Now, pain control is big here because of the localization of the pain, especially in the costovertebral angle. There's also that pain when they're initiating that urine stream. That is very significant. So our patient definitely needs to get their analgesic as ordered. Also, the application of the warm compress to the flank area, and this will also reduce the painful sensation. Now, along with that, we have to evaluate the response to the pain control and make sure that we are documenting that and telling the doctor or the medical provider that maybe the patient is not getting any type of pain relief. Now, part of the care here is to maintain education to the patient, make sure that they know about the disease process. That is very important. So they will know what to watch for, what manifestations that they need to report to the medical provider, and also to discuss the importance of completing the full course of the antibiotics and also the need for them to show up for the follow-up visits and also the follow-up urine or blood cultures. Now, part of the care here on the preventive measures will be about the fluid intake, the personal hygiene, and making sure that they are maintaining much more of healthy urination habits. Now, we're going to tackle these tests here. I probably prepared about 4 or 5 of them. So let's tackle this first question. So the scenario states, what symptoms should the nurse expect in a patient with acute pyelonephritis? Is it A, pain at the lower back where the ribs and spine meet, along with the sudden shivering episodes? Is it B, painful urination with burning sensation, and C, yellow skin and side pain or the flank area? Or D, frequent urination and waking up at night to urinate? So take your pick. All right, I hope that you were able to get your correct answer in time. All right, let's go through the scenario one more time. So the scenario said, what symptoms should the nurse expect in a patient with acute pyelonephritis? Again, limit your imagination here about acute pyelonephritis. So anything of those manifestations that involve the chronic pyelonephritis, and for those manifestations that are not shared between the two, should be discarded. Okay, that would be my trick here. Now, A, pain at the lower back where the ribs and spine meet, along with the sudden shivering episode. Well, that is a possible answer. It's because the infection itself is severe, it's sudden, and it typically would present a much more specific manifestation in the costovertebral angle, in the flank area. And this is where the ribs and the spine meet. And of course, the person will manifest the different manifestations, of course, with the shivering. That's part of it. And the chills. And this is because of the combination of the kidney involvement and also the possible infection of the nearby tissues. Again, this is going to be our possible choice. Now, let's take a look on letter B. Let me change my pointer here. Letter B, painful urination. So what is this? Painful urination with a burning sensation. While it is going to be a bit helpful, and also the burning sensation are also common manifestations of the urinary tract infection. However, this is not really specific to the pyelonephritis itself. This can also be a shared manifestation in a urinary tract, especially the lower side, the urethra, the bladder, not really the kidneys. And again, these manifestations are not sufficient to help in the diagnosis of the pyelonephritis. So again, focus into the acute pyelonephritis, the association of the manifestation, something that you need to decide here. Now, for letter C, yellow skin. So what is that all about? Yellow skin and flank pain. Well, we did not talk about the changes in the color of the skin in acute and chronic pyelonephritis. However, this is something that you can see in a patient with a liver or probably a gallbladder issue, or it could be a hepatitis infection, or maybe an obstruction in the bile duct, and it's not gonna pinpoint the pyelonephritis at this point. Now, even though it says flank pain, it's going to make the option half correct, half erroneous. Now, what about letter D? Frequent urination and waking up at night to urinate. Well, with this kind of manifestation, these symptoms can suggest that there is probably an overactive bladder, or let's say lower urinary tract infection. And again, this is probably going to be shared again with the overactive bladder, but it's not really that specific to the acute pyelonephritis. And again, this is something that you are going to put in the parking lot. This is not really the best answer that we are looking for this time. So we are left off with, what answer is that again? That is going to be the pain at the lower back where the ribs and spine meet, along with sudden shivering episodes. That is the correct answer. Now, again, our test taking strategy here is going to involve understanding again about the condition that we're talking about. So recall those manifestations between the acute and the chronic pyelonephritis. And again, the appearance of the pain in the costovertebral angle is the main feature, and also with the appearance of the shivering, the chills. All right. Now, part of the strategy here is to also differentiate the symptoms, like I've said, because there are a variety of symptoms that are not shared between the acute and the chronic pyelonephritis. Now, and also the liver problems, we don't have that yellow skin, okay? Should not be part of the renal problem here. Eliminate this one right away. Now, also you have to focus into the keywords and also the test question, especially it's saying tenderness, the junction of the ribs and the spine, okay? And also the shivering. These are close associations with the pyelonephritis already. Now moving on to the next item, which says, which is the most relevant guideline should the nurse teach to a patient recently diagnosed with chronic pyelonephritis? Again, which is the most relevant guideline should the nurse teach to a patient recently diagnosed with chronic pyelonephritis? Is it A, anticipate taking antibiotics for several weeks or even months? Or is it B, be prepared to submit a urine sample for culture every 2 weeks for up to 6 months? Or C, plan to regularly use pain medication for the next 6 months? Or is it D, stay in bed for up to 14 days? That's quite easy to spot. All right, I hope that you have already selected your answer. So let's go through the options here with letter A. Anticipate taking antibiotics for several weeks or even months. A good possible answers, because with the chronic pyelonephritis, this is going to be a persistent infection, recurrent infection that can also necessitate the use of much more extended antibiotic therapy. Again, it can last from weeks up to months. And the reason for that, again, is to prevent the resistance, antibiotic resistance, and also to prevent the permanent kidney damage. So that is our possible answer. What about B? Be prepared to submit a urine sample for culture every 2 weeks for up to 6 months. Kind of like sounding so good, too good to be true here, but we did not mention about having to do this very often, like every 2 weeks, up to 6 months. That is an overkill. So the collection of the urine culture or the sample itself is going to be done at least 2 weeks after the completion of the antibiotic treatment. And this is to verify that the infection has been clear. It's not going to be every 2 weeks, but after 2 weeks, once the antibiotic has been completed. All right. Now for letter C, we are marking this as X. What about letter C? Plan to regularly use pain medication for the next 6 months. Well, same thing with the letter D, stay in bed for up to 14 days. These are some sort of an overkill as well. So even though we're gonna provide them adequate bed rest or let's say pain relief with the prescription medication, this is only going to be required during the acute phase, right? But these are not something that you're going to implement into this person with a long-term requirement. There's no way that they're going to be able to do that. A whole lot more of complications can arise when you're going to allow this patient to stay in bed for 14 days. That is way too much. So eliminating these two immediately, these are unrealistic nursing interventions. Now, for the test taking scale here, again, you're going to have to read through the question carefully. You have to understand what is being asked. Focus on the keywords, chronic, or the keyword itself, the chronic pyelonephritis, okay? And another thing is to recognize the terms related to the duration and the type of the treatment that is going to be required for the chronic conditions. So that's one. And to also eliminate the incorrect options. So those typically not part of a long-term management, like bed rest. That's not going to be a long-term management for the pyelonephritis, like the chronic type. Same thing with the pain medications. There's no way that you're going to be allowing the patient to be taking that same pain medication for quite a long time. Now, what we're going to look for here in this scenario is to identify a much more of like a comprehensive treatment for a chronic condition. So this is really something that will address the long-term problem, which is basically the anticipation of administering or teaching the patient to take their antibiotics for several weeks. All right. Now moving into the third question here. A patient admitted with acute pyelonephritis is scheduled to begin antibiotic treatment, and which symptom is the nurse likely to observe? We're talking about acute pyelonephritis. Okay. So they're scheduled to begin antibiotic treatment. So which symptom is the nurse likely to observe? Is it high blood pressure? Is it pain in the side where the kidney is infected? Or is it C, discomfort spreading to the opposite side? Or is it D, absence of soreness when pressing deeply over the kidney area? Again, recall the differences between the acute and chronic pyelonephritis. All right, I hope that you have picked your answer. Now we'll go through the options here. For letter A, high blood pressure. Well, there is hypertension, but this is going to be associated with the chronic pyelonephritis, not acute, okay? It's not a typical manifestation of acute, so get rid of this one immediately. We did not talk about hypertension, okay, in the acute pyelo. What about letter B, pain in the side where the kidney is infected? Well, the pain of this patient, especially with the acute pyelonephritis, will not radiate to the unaffected side. Again, I said unilateral. If the infection is only involving one side, or let's say the right, or could be just the left side, then the pain will be limited to that infected kidney only. It will not cause some painful sensation to the other side. So the radiating pain could suggest that there's any other condition. It could be renal stone, or it could be other musculoskeletal issues. So again, pain in the side where the kidney is infected, yep, telling us that there is unilateral, localized type of pain, possibly their answer here. Now, talking about the C, discomfort spreading to the opposite side. Well, here, the pain from the acute pyelonephritis will typically, again, not radiate to the unaffected side. And again, it is localized to the side of the infected kidney, and there is no radiation. Okay? We are going to eliminate this one as well. What about letter D? Absence of soreness when pressing deeply over the kidney area. Well, let's find out. This is going to be an erroneous answer. Again, the lack of tenderness or the absence of tenderness would be atypical in acute pyelonephritis. It's totally the exact opposite, okay? So what we're going to expect in a patient is going to be that costovertebral angle tenderness, especially when we are palpating that area. And this is supposedly present, okay, because of the inflammation already going on inside the renal parenchyma. So we are only left with correct answer, letter B. Now for the testing strategies here, we are going to understand the condition again, differentiate between the chronic or the acute pyelonephritis, and in this scenario, we're only tasked to investigate further of what the symptom is in acute pyelonephritis. And another thing is we are going to identify those key symptoms, especially the flank pain, the costovertebral angle, and there is no radiation, it's localized. And so for those other manifestations like high blood pressure, again, this is not associated with acute pyelonephritis. And also the absence of the tenderness, letter D, is also going to be eliminated. All right. Now let's move forward to question number 4. A patient admitted with acute pyelonephritis is scheduled to begin antibiotic treatment. So which symptom is the nurse likely to observe? Is it A, refrain from consuming dairy products, or B, come back for repeat urine tests, or is it C, discontinue the antibiotics once the symptoms improve, or D, relapse is rare because you've been treated with antibiotics? So our scenario here is involving acute pyelonephritis. And of course, patient is getting ready for the discharge, but you are the nurse doing the discharge teaching. And so what is that advice that is very important for you to give to the patient? So let's go through the different options here. For letter A, refrain from consuming dairy products. Well, avoidance of the dairy products really does not impact the treatment of preventing the pyelonephritis. And also the dietary intake of dairy does not really affect the condition or its occurrence. So immediately cross this out. Now, letter B, it said come back for repeat urine tests. So it's like a similar, actually, type of question that we had in probably question number 2, I think. So here, it's very important that the patient will be taught to come back for a follow-up urine culture, and also make sure that we are checking into their urine to see if there's already eradication of the bacteria, or if we still need to continue the antibiotic therapy. So that's a possible answer. Come back for repeat urine tests. And C, discontinue the antibiotics once the symptoms improve. Oh yeah, you can eliminate this right away. We were never taught in nursing to allow the patient to stop taking their antibiotics once they feel better. Never. So again, the compliance in the entire regimen, antibiotic regimen, should be done by the patient. You want to make sure that they are taking the entirety of the dosing schedule in order to prevent resistance to the antibiotic, and making sure that we are eradicating the bacteria from their urinary system. Now, let's take a look into letter D. Relapse is rare because you've been treated with antibiotics. This is a huge false reassurance here. This is very misleading, as we know that the pyelonephritis is something that can recur, right? So this is false reassurance saying that relapse is rare. We never said that. It was never mentioned about rare relapse. So again, the reasoning behind that is because the pyelonephritis can recur and also can develop weeks after completing the antibiotic therapy. So that's how some of these microorganisms are pathogenic. They're just not going to respond to some antibiotics. And that is why careful monitoring of the patient's blood urine culture should be done once the antibiotic therapy is completed, about 2 weeks after. Now, what are the key strategies here to answer this question? Again, we are going to focus on the keywords here, like most crucial advice and also discharge guidelines. So this will really make you think about what kind of teaching or those information that need to be imparted to the patient, something that they need to really understand, so that they can manage their illness at home. Okay. Now, another is that we're going to have to eliminate those clearly incorrect options, especially for some options here that are not relevant, like the food, the dairy intake, and also giving false reassurance, and also letter C, telling the patient to discontinue once they feel better. So those are obvious negative nursing actions. Now, we're also going to talk about the properly identifying the condition that we are trying to resolve here. So again, recall in what kind of treatment is involved in the acute pyelonephritis, the potential complications, and what possible signs that you should be preparing, especially if there is antibiotic resistance. And also making sure that they are going to adhere to the follow-up appointment in order that we can do the urine testing as well. Now, another thing that you need to be careful when checking into the question is for those absolute statements, especially for those terms like never, or let's say always, or rare. Those are some clues that probably would be kind of like that you can help out, that can really help you out in identifying that this item or this option is incorrect, because these are absolute options or terms. Okay, they don't really account for the individual variations between the different types, and so you got to be careful with those words as well. Again, always, never, rare. So those are the keywords. Now, that's the end of our lecture today, and I thank you for your attendance. So I hope to see you again tomorrow. We'll be talking about the polycystic kidney disease tomorrow and hydronephrosis. And again, we are encouraging everyone to invite their friends, trying to pass the NCLEX. Make sure that you tell them about the free reviews that we are offering for the entire 90 days. It's free. And we're going to be moving forward to the 8th day in our review tomorrow. And so we're also promoting our offer with the courses that we are having in our website at www.stancoastandclexcoaching.com. Please grab the opportunity, especially that we have a 70% discount for this month only. And you have all the perks contained in here in this slide. And also you can check out onto the description box below. Again, thank you so much for your time, and you have